So first off, I just wanted to thank Richard and the organizing committee and Scott Halpern in particular from the organizing committee for the opportunity to participate here on this very, very important topic. Next slide. So I have a few disclosures that will be available. Importantly, I should mention this has no relation to my work as a commissioner on MedPAC. And next slide, please. So as we think about payment approaches, and Tisa Marie did a fantastic job. I mean, did a fantastic job of kind of laying out some of the very specific details around this. And what I will do is kind of take a step back a little bit and think about the macro approach around what we know in terms of specialty-oriented or specialty population-oriented payment models, and what might a path forward look like, in particular in light of the evidence that we do have versus where might we need more evidence, and then touch at the end upon this point that that was already discussed or at least teed up in terms of how do we link payment to organizational change. I think one thing we have to recognize just up front is that the existing broad payment reform type efforts that do exist, that we could put into 4 categories here at least. I have done so for simplicity: episode-based type models, which start with some triggering event and then conclude at some predefined period afterwards, whether it's 90 days or 180 days, generally have been focused around hospital and or specialty care. A second approach being population-based approaches. This is a la our accountable care organization, shared savings, direct contracting type of programs that Medicare has used, as well as other private payers have used in the context of ACOs primarily. These are models oriented towards managing all care for a population, where you can imagine for a second that ADRD and patients with ADRD don't necessarily figure as a very large proportion of the spend. The third bucket being full capitation or global capitation. These models have been used in the private and Medicare sector, primarily in the Medicare side and Medicare Advantage. And we've heard a little bit about that previously from Dr. Sherry. And then comprehensive primary care, where the idea is to motivate primary care practices, a la patient-centered medical home and the like, to innovate how they provide care in an integrated fashion, ideally for patients who have special needs or high needs. The unfortunate reality, I think, is that none of these payment approaches is a great fit for patients with ADRD. There are a variety of specific needs that we know that patients with ADRD end up requiring along their care journey, if you will. And that longitudinality, as well as the need for avoidance of intensification at times, which whether it be ICU admissions, hospitalizations, mechanical ventilation, there's obviously a big role around nutrition, feeding tubes, other supportive care that's fundamentally important, but that requires an intensity that I think, based on what we understand to date of how clinicians and organizations respond to payment models, is likely not a good fit with any of these approaches, as I will talk about in a moment. In general, the evidence, broadly speaking here, as Dr. Sherry pointed out, is startlingly thin. And if we can go to the next slide, please. I think what we need to do is kind of differentiate where we do have evidence and where we don't have evidence. And I think there's a potential vulnerability here, or potential misstep we could take by conflating 2 ideas and opportunity to separate them. And there is evidence that looks at existing models, like bundle payments, for example, for patients who've been admitted for medical conditions like congestive heart failure, pneumonia, diseases that undoubtedly do afflict patients with ADRD, but evidence that focuses on how those models affect patients with ADRD. And that's kind of the left-hand side, if you will, of this slide. On the other hand, we have to think about how these payment approaches, in fact, affect ADRD care itself and ultimately the outcomes of individuals with ADRD, not necessarily just in the short term of, say, a 90-day episode, but really in the long-term achievement of their goals and their family goals. And I think right now the preponderance of evidence that we have is really weighted on the left side, not on the right side. And it can be tempting perhaps to look at the existing literature and say, well, we do have some evidence around how ACO approaches and or episodes seem to affect care for patients with ADRD. And by and large, that evidence seems reassuring in that patients do seem to be engaged in care redesign. There was this nice study done by folks at Lewin Group, Brandon Mon and colleagues, that looked at bundle payments for care improvement program and found that these individuals yielded the same or benefited from the same types of care redesign efforts with no worsened quality, at least that we can coarsely detect through claims. Similarly, there's literature about ACOs that shows that individuals who live in institutions or long-term care, that they tend to have fewer hospitalizations. This is work by Julie Bynum and colleagues. So I think we could look at this and say, well, maybe we're on the right track. And I think to some extent, this is more of a positive in the scorecard, if you will, of these payment approaches, rather than a positive to connect them to the right-hand side, which is, so how is this actually affecting truly the longitudinal care of individuals who are suffering from ADRD? I think that's a distinct difference. And when we have had the opportunity to do, in a very select few cases, studies that take that next step and dive underneath these payment approaches, I think we start to reveal things that may be a little bit troubling. So for example, there's some work by Chen and colleagues that suggests that ACOs may in fact avoid patients who have conditions like ADRD because of the intensity of spending as well as the intensity of care associated with them, and that this can actually interact with racial, social, and ethnic disparities as well. And so I think that's an important challenge for us to recognize, and also an important distinction for us. If there's one thing I can have us leave from this session, I want us to leave this session recognizing there's a difference between how current payment models affect patients with ADRD for non-ADRD care versus how we're actually affecting their ADRD disease trajectory, if you will. More comprehensive approaches perhaps may be more effectual. There is some evidence that in Medicare Advantage, for example, there is better end-of-life care. Dr. Sherry alluded to this. There, for example, can be less death in hospital, less use of mechanical ventilation for patients with ADRD or institutionalized beneficiaries. That being said, that's counterbalanced with some concerns around, is there some selection in MA? I think we have yet to see a truly definitive study to reveal exactly what's going on here. There are also certainly technical challenges for this population around areas like risk adjustment. And so as we think forward, if we can go to the next slide, please, I think we also have to take this into a context that, unfortunately, changing payment, as we have seen Medicare and other payers try many times, has not yielded a direct result on the organizational model that we desire. And so what we need to do to some extent is start with the organizational model and say, how do we want to deliver care in this context? Some of the areas that are really important in the context of ADRD that I would say are insufficient in current approaches include things like caregiver support and incorporating caregivers. Dr. Sherry also mentioned that. Medication management, self-management, psychosocial interventions, the longitudinality of care coordination, the treatment of related conditions, medication management. These are all areas that are fundamentally important to high-quality ADRD care that don't figure prominently in the other approaches because at the end of the day, again, as I mentioned, ADRD patients tend to comprise a relatively small proportion of the spend and panel for these for these provider groups, for clinicians and healthcare organizations. So the type of testing, if I can speculate a little bit about where might we need to go, I think on one hand, we need more specialized approaches. What we have seen overall, if I put my behavioral economist hat on for a second, I would say one of the big challenges for population health models is salience. So if I'm a primary care clinician, if I'm a geriatrician, in my panel, the number of patients with ADRD may end up being quite small. So how do I make this more salient? How do I engage the clinicians? Well, we create a model that has some sort of specialized nature to it. The tricky part is if we over-engineer that model to be very narrow, a la an episode, then we're probably freezing out the type of longitudinal care that we need. And so what I speculate may be an approach here to test, and this could be CMMI or other payers or in combination with states on the LTSS and other sides that Dr. Sherry mentioned, is maybe there's an approach here where we have a baseline type of population payment model approach to provide an investment in the care infrastructure that would be needed, but then supplement that around episodic type of care. Because if we don't supplement around the episodic care, again, we may not get enough focus on these populations. If we do have an episodic notion of how we pay as well as measure the care, then we may get enough activity, care redesign efforts focused around the very places that we have articulated earlier to get a model that's actually tailored toward these individuals, but that's salient enough to the clinicians to actually, and provider organizations to actually engage in redesign care to incorporate those aspects. I will say, I take this, I would say take this all with a grain of salt. There's not a lot of evidence here, more some musings around how we might try to test new models. And I will say I've been routinely humbled. I have had the pleasure of working with health plans to design new models, and it is very challenging to get this right, to really create a proper link between the payment model side and the organizational care delivery model side. But at the end of the day, that's why we test, that's why we do research, that's how we try to learn. So I will close here. We can move to my next slide. I will close here and say it was thank you again for the opportunity. I look forward to the panel discussion. I hope that I contributed some conceptual grounding thoughts that link to the practical thoughts that Dr. Sherry gave earlier. Thank you.